Sounds great. Well, thank you, everyone. And thanks to all who joined us this morning. I know we've got a few people more trickling in, so we'll just welcome people as they come. But my name is Laura Summers, and I'm the Senior Healthcare Analyst at the Kempsey Gardner Policy Institute. And I'm very excited to welcome everyone to our virtual Newsmaker breakfast. We appreciate everyone being here as we continue our monthly breakfast in a virtual format, at least for this time, hopefully coming back in person at some point. Just a couple of quick housekeeping items before we jump in. We have disabled the screen share and the audio features for all participants except for our panelists. But if you do have any questions or concerns, you'll be able to submit those in the chat box for later in the event. We encourage you to do so, and we'll try to get through as many of those questions as possible. And our communications director, Nick Therio, will help facilitate that. So for today's topic, we are very excited to be discussing Utah's current and future healthcare needs. As we kind of move out of the pandemic, and I say that just having come out of COVID myself, so I think I jinxed myself by picking this topic. But we certainly know that there are other key issues facing Utah's healthcare populations today. So what we want to explore today are what are those current and future healthcare needs? What are those key issues? Have those issues changed since the onset of the pandemic? And as Utah's demographic profile continues to change, what do we really need to be thinking about now in order to address the future healthcare needs of our state? I'm super excited for our panel today. We have an all-star panel of healthcare leaders who will be helping us understand the critical healthcare issues facing Utah today. Our panelists are Nate Checketts. He is the Deputy Director of the Utah Department of Health and Human Services. Nate previously served as the Executive Director of the Utah Department of Health before the consolidation, where he oversaw Utah's COVID-19 response. And he also coordinated Utah's COVID-19 testing efforts, has served as Utah's Medicaid Director, and helped in the design and implementation of Utah's Medicaid expansion. Riley Curtis is our next panelist. She is the Director of Community Engagement at the University of Utah Health. She has worked on Medicaid policy in Utah for many years before joining the University of Utah, and in her current role leads the hospital's anchor institution work, conducts a community health needs assessment, and is developing the social determinants of health screening processes with an emphasis on partnership and co-development with the community. And certainly last but not least, we have Mikkel Moore, who is the Senior Vice President and Chief Community Health Officer at Intermountain Healthcare. She has been part of Intermountain's leadership team for more than 20 years and is a pioneer leading healthcare's pivot toward addressing the social determinants of health, preventing avoidable disease and injury, and improving mental health and well-being, all to support Intermountain's mission of helping people live the healthiest lives possible. So let's just kick off in the discussion. I wanted to open up, I know first with Mikkel and Riley, both Intermountain Healthcare and the University of Utah have been engaged in efforts to assess the health needs of the communities they serve. They've recently been engaged in this effort. So I thought we'd kick off with sort of the most pertinent question to you, Mikkel. I know it's probably hard to boil down to three, but what are the top three health issues, maybe 3 to 5, or concerns that you all have been hearing from the community as you all have engaged in these community health needs assessments?
Well, thank you, Laura, for the question. And first, I want to acknowledge that Intermountain and the University of Utah, along with our health departments across the state and many other partners, have been conducting health needs assessments together. And so appreciate that partnership, Riley and Nate. I think it's really important that we're listening to our communities together. And what you described, Laura, is exactly what we have to do. Kind of think about what are those, listen, first of all, to the needs and the assets that exist in every community, and then try to distill, okay, what are we hearing? What are those top issues that then we might organize around addressing? And Intermountain has just, based on that needs assessment, prioritized the three issues and concerns we're hearing from our communities that we think we can be active with them in addressing. And while that's hard, that I think above all, the number one issue we continue to hear about in our communities are concerns around mental health and well-being. That topic is shifting a little bit, and I think we can even talk about it, but it's talk about it in further detail. But people seem generally concerned for everyone's mental health and well-being. Whereas years ago, when this first emerged as a top priority for us, it was really around more severe or acute mental illness, concerns around suicide prevention. And people are really worried about just general anxiety, depression, and its impact on their families, their work environment, all aspects. And then continuing concerns around preventing chronic disease, the chronic diseases associated with obesity, and also injury, particularly to kids. Some concerns about continued concerns around suicide prevention, but also vaping and other avoidable injuries. And then, lastly, the topic that for us has become a kind of a forefront topic instead of a background topic is concerns around social well-being. The social determinants of health, as we refer to them, all of those non-medical things that contribute to our health and well-being are top of mind now for people in terms of when they think about the health needs in their community. There's concerns about access to housing, and then the affordability of that housing in addition to its accessibility, and concerns around access to healthy food and nutrition. And really, these social well-being factors have emerged as top of mind in nearly every community we talked to, Laura.
That's great. And I think that's so interesting, just the change or the things that are the focus now. Definitely related to healthcare. I think everyone in healthcare understands how critical they are in terms of impacting a person's health and health outcomes, but interesting that it's starting to percolate down to the broader community as well. So Riley, along those lines, just wondering if there's anything you would add to that list, or if there's anything notably different from this year's assessment compared to previous years.
Yeah, I think two things that I'll add to what Mikkel had said was that I thought it was really interesting that even though we had just come out on the other side of a pandemic, it did not take over the conversation. So COVID was not the one thing or the top thing that community partners brought up or talked about. But what I thought was interesting, and Mikkel touched on this, was the interplay of how each of kind of the three priority area or few priority areas that community partners brought up, that they all impact each other. So, COVID really highlighted mental health issues, right, for people, isolation, keeping children out of schools and what that does to adolescent mental health. How can health systems address behavioral and mental health if we're not addressing housing, right? Because people can't be mentally or physically sound if they're worried about their health, if they're worried about where they're going to sleep at night, right? And so there was a lot of conversation about the interplay of how these different issues affect each other. And then I think the last thing that I would add is I think COVID also amplified and gave people the right language to talk about health disparities and access to providers that understand cultural backgrounds or speak, the language, the preferred language of the patient or the community that we're trying to serve. And we saw that, I think health systems truly started to understand why this is important when we saw the health disparities shaking out with COVID vaccines and COVID rates and COVID, deaths as well. So I have more to say on that later, but I think those were the things that I would add to what Mikkel said.
That's great. Thank you so much. Mikkel, I was going to turn back to you. I believe Intermountain did these health needs assessments across the state. And as we all know, Utah has very rural areas compared to the Wasatch Front, which is very urban, even some frontier areas. I was just wondering if you were seeing any meaningful differences between the urban and rural areas, or any different issues that were really popping up in our rural areas.
Well, I think yes. What surprised me is actually how similar the issues are, almost, and that's the nuance. So, I think we, Intermountain's been working on housing solutions, for example, Laura, and most of the housing partnerships that we have built have been in urban areas because that's where we have found the ability to partner, and kind of projects that are ready for our investment. And what really shocked me, in rural communities, housing issues are maybe even more severe in terms of their impact on people and communities. There's just no housing available. Not that it's not affordable, there's really a shortage of housing stock that has been exacerbated throughout the pandemic as people have moved into some of our rural and tourism drawing parts of the state that have attracted out-of-state buyers or investor buyers and reduced the housing stock in total. I think even during the pandemic, there were some kind of emergency driven solutions also to turn hotel space and other assets like that into housing in various communities. And those emergency efforts have run their course, and they're reverting back to the existing zoning policies and rules that have been in place in these communities. And so as a result, what some of our rural communities are really facing is a shortage that's exacerbating their workforce shortage issues. And certainly you can see the impact that has on mental health and stress in communities, and the ability to meet the demand for overall healthcare needs in a community. So there's some things that surprised me about, in terms of almost how similar the health issues are in communities, even as they're exacerbated by some of the uniqueness of our rural communities. I think the other thing I'd say is that any of the gaps in access that exist in our urban communities are further exacerbated rurally. And, just no availability of mental health providers and professionals, which makes the access to mental health even more difficult. And we found a lot of solutions during COVID that we've utilized around telehealth and other capability that is showing promise. We have problem solved a number of, we've identified broadband and the digital divide disparities that exist in our rural communities. And I believe are at the beginning of finding really lasting solutions to those issues. But the gaps are still notable at this point, Laura. And so I think that's what I'd highlight: the digital divide, the true access barriers that exist, and then this nuance around how the social determinants of health are playing out in our rural communities.
Laura, could I follow up on one of those points?
Yeah, absolutely.
So just following up on one thing that Mikkel said about housing, I'm down here at the One Utah Summit in Cedar City, and yesterday we met with a bunch of individuals related to rural health, and they did bring up housing as one of the issues. And it was sort of this Airbnb factor that they described, that they said where individuals have come in. She mentioned the investors and others that have come and purchased some of the limited housing stock with the primary purpose of renting it out on Airbnb, and that just pulls it out of the availability for healthcare workers, for other people that are trying to live in the community, and creates that shortage that she talked about. So I just wanted to echo that was something the community raised yesterday in our discussions with them here at the summit.
Yeah, that's a really interesting point. It's kind of, just personally, it's kind of turned me off from using Airbnb and VRBO, just because of realizing the impact that it has on those smaller communities and the lack of housing stock. And I was just going to note, we're doing a behavioral health assessment, working with the department and the Utah Hospital Association and Levitt Partners HMA on that. And housing was the number one issue that came up as we were talking to people about gaps in Utah's behavioral health assessment. It was so interesting to hear, no matter which group we were talking to, whether it was providers, people with lived experience, payers, housing came up in all of those and was the number one issue in many of those groups. So
And Laura and Nate, what shocks me is it's at almost all income levels.
Mhm.
I think we've been addressing it as a low income housing gap. It seems at all income levels, there's accessibility problems, and it's changing the way I think we have to think about solving it in communities too.
Yep, absolutely.
Yeah, we've talked about healthcare as an affordability issue for many years and the cost of healthcare. And while I think the cost of healthcare has risen recently, I think the pressure from the housing rising so rapidly has just put a pressure on families' budget. To Mikkel's point, low income family, moderate income families, it's a huge pressure. And so it's crowding out other things. And healthcare is one of those things I think that is filling that squeeze of there's just not enough dollars in the average family's budget to cover things. And healthcare is filling that squeeze right now.
Yeah, absolutely. And I wonder if it's some of that is to come as well. I think people are starting to feel that squeeze, and I worry that it could be exacerbated as we continue into just increasing inflation and potential recession. Hopefully not, but Riley, I wanted to jump to you. I know in addition to rural area issues, I believe this was the first year where both Intermountain and the U of U made a really concentrated effort to conduct a Spanish language group or several Spanish language groups, which I think is great, particularly as it reflects just the growing diversity in the state of Utah. And just wondering what the outcomes were, what the benefits were of doing that group and what some of the outcomes were, and if they were different from the broader community groups that you ran.
Yeah, thanks, Laura. I'm really excited that we were able to host this conversation. And I just want to call out again, it's the Community Health Needs Assessment collaboration. So it's really in partnership with Department of Health and Human Services and several other local health districts across the state. But we had a conversation about the pros and cons and how do we pay, because how do we pay for the interpreter and the facilitator and the transcripts and all that? And we decided that this needed to be a priority as a collaboration. And so I'm pleased to announce that we move forward with it. I would love to do more languages in the future, because what I think we learned was that for years, we've been inviting Spanish language communities into these conversations. But when you put them into a room with everybody else, it drowns out their voices and their unique experiences within our large systems. And so when we had the conversation in Spanish, facilitated by a Spanish speaker, the energy was palpable, both from the facilitator, but also from the organizations. And it became clear to us that these groups, they really have been motivated to address their own identified priorities for years, with or without large systems. But boy, could they get a lot further if systems listened and invested and partnered with them. And a couple of examples of that are our friends at Latino Behavioral Health Services. They started with a small seed grant out of University Neighborhood Partners, and same with Comunidad Materna in Utah. Both of these were Spanish language community identified issues, maternal health and birth outcomes, as well as behavioral health access for Spanish speaking communities. And these nonprofits started, and now they're flourishing, right? There's this need they identified. They're training Spanish-speaking peers and doulas across the state of Utah, and they're making a difference. And I think what we learned as health systems and large systems was that transformative solutions are already in the community, and it's our role not to solve, but to partner, convene, and to amplify those voices. And doing this conversation in Spanish, hosting it, is one of the ways that we get closer to doing that. And so I think the other thing that we learned, and that was highlighted in those conversations, that was through COVID, a lot of trust has been built with diverse communities. And so we see that with the increase of community health workers, lots of grant funding went into that for COVID outreach. But we need to continue to build on that trust and continue the dialogue and find sustainable funding solutions for community health workers, because they really do act as cultural brokers between large systems and communities that are disparately impacted by things like COVID or housing or whatever it might be. And so to summarize, I think that what we heard in those conversations really boiled down to barriers to access, lack of culturally responsive care, and mental health needs. So And what I was saying earlier was the interplay between like addressing health disparities and mental health. There is a total lack or need for mental health services, but for Spanish speaking communities specifically, there's a serious deficit of bilingual and bicultural providers, and that exacerbates the behavioral health and mental health problems. And then I think just generally there's fear, there's trust issues, there's systemic racism that have locked people out of accessing systems historically. And then again, this lack of culturally responsive care. And so I think there's a lot that we learned, and there's a lot that we're all hoping to do to partner with these community members in the future.
Yeah, absolutely. I think that's resonated, and we've heard similar things in the groups that we've conducted as well. And just the importance of having the culturally and linguistically appropriate providers, which gets into a whole other conversation about workforce and testing and licensing, which are big issues. And I wrote this down because I thought it was great. The transformative solutions are already in the community. I think that's such a great line, truth, and so important for us to remember that as we, engage in efforts to improve the system and assess the system as well. So. Nate, all right, well, I wanted to jump to you next. And I know the department has been part of this collaborative around community needs assessment. I know just in general, the Department of Health and Human Services is always keeping a pulse on the health needs of our community, including our state's changing health needs. So just wondering if you've seen any significant changes in health needs or outcomes over the past couple of years, particularly, as the department has really been focused on COVID-19 and its response there.
Yeah, thanks for that question. And as you mentioned, a lot of things have been changing over the last couple of years. Some of our data is still coming in on this. And so as we do some of our assessment and analysis of 2021, we're still getting some of that data. And so we assume there will be some significant changes there, but we haven't had an opportunity to collect all of that information yet. As we look at some of the data that we have related to our service provision, particularly in the Medicaid area, we can really see some dramatic changes and not unexpected, but I thought it might be interesting just to walk through one of those related to telehealth. Telehealth was always, not always, but for a long time has been available as a Medicaid service, and providers could use telehealth to provide those services. As a program in calendar year 2019, we received about 4,000 claims that were labeled as telehealth or billed as telehealth claims. And we were excited about that and happy that providers were using that. Not surprisingly, that grew in 2020 when many providers couldn't see patients directly, and our numbers jumped up to 535,000 telehealth claims billed in 2020. And as the world reacted to the fact that they didn't have an opportunity to go see their providers for a period in person. And that trend, those numbers, although they've come back down somewhat in 2021 as providers reopened their offices and began to see people in person again, we still saw 469,000 claims come in 2021 under telehealth. So you just look at that difference from 4,000 pre-COVID to nearly 400, over 450,000 claims in the last year. How rapidly that has grown as a service delivery model. One of the areas that we've worked on as a department, so our billing requirements and the rules and the laws related to this talked about having audio and video as being part of that telehealth service provision. And in the rush and the press of 2020, we made some changes, some emergency changes to say we would allow audio only service provision to count and be billed and fit Medicaid rules. And that's something that we've decided we can incorporate on a long-term basis. And so we've implemented through rule change in the Medicaid program to allow that audio only as a mode to be able to continue that service provision. And we really think that opens up a lot of opportunities. We talked earlier about some of the struggles in the rural areas and being able to get specialists in, and how do you support a specialist in San Juan County? Are there enough residents? Is there enough need on an ongoing basis to support a full-time specialist. So options like telehealth allow a local practitioner to be able to partner with a specialist that may be in an area that doesn't have a lot of need on an ongoing basis to be able to do that. So we're really excited about having those options available, and we think those will be an important part of service provision as we go forward.
Yeah, I think that's so important. And the audio only, just hearing little bits and pieces, but how critical just that component can be, particularly, Mikkel, I think, as you mentioned, the digital divide and some of the challenges there. So.
And
Well,
as we've heard,
go ahead.
I was just going to add one more point related to that. As we've talked to providers, providing services solely through telehealth, providers and patients report that that isn't necessarily the best way to do that on an ongoing basis, but to have that as available as a mix or a part of the mix is a key part. So we talked about mental health, substance use, those types of issues. To be able to check in and have a discussion from time to time on phone and do that audio only is a good part of that development. And then have some time where they're coming in as a group or coming in and to have an in-person visit. It just sort of rounds out the options for providers and patients as they're seeking care.
Yeah, it creates that additional support. So it helps potentially alleviate some of the workforce challenges as well. So. Well, I wanted to jump. I know our health systems are focused on addressing current healthcare issues. They're also constantly looking forward to understand and get ahead of any emerging healthcare issues as well. So as we all know, the state of Utah has undergone a lot of changes over the past 5 years. I always tell people, Utah looks very different today than it did 10 years ago. In some ways, I almost think it looks very different today than it did like 5 years ago. But to help frame this portion of the conversation, instead of me just sort of applying my own thoughts, I wanted to invite Mallory Bateman, who is one of our demography experts at the Gardner Institute. She's just going to provide a really quick snapshot of Utah's changing demographics. And then I'd invite all of our panelists to kind of respond in terms of how they're thinking about this or seeing this in terms of healthcare as well. So Mallory, thank you for joining us.
Thank you. And I'm going to try to share my screen and hopefully that will work. Okay. So we're going to start out actually looking at the estimates from the past year. So 2020 and 2021 are the most recent estimates we have. But if we look back between 2010 and 2020, we were the fastest growing state in the nation. We added about 500,000 new residents, and that was around 18.4% increase. But it was actually kind of lower than it had been for the previous 2 decades. And nationwide, the growth rate was very low, lowest that it had been since around the 1930s. So if we look at this most recent data, which is on this map, some similar states popped to those that popped between 2010 and 2020. Utah and Idaho were the 2 fastest growing states in this 1-year period. We were the second behind Idaho. They just barely beat us. But, a large part of that was due to the higher than kind of average deaths due to COVID, declining birth rates that we've been experiencing for quite some time. And then migration has been really muted, both due to some policy changes as well as, COVID making a big impact on that movement of people. So if we look at all of this movement and all of this growth, most of the growth in this 1-year period was driven by migration rather than births minus deaths, which is kind of one of the things that we rely on in Utah. That last decade, that intense growth we experienced was about 2/3 from natural increase, which is the births minus deaths, and then about 1/3 was from migration. So looking forward at Gardner, we produce long-term planning projections for the state and counties, and we released these in January of this year. And we project that looking out to 2060, we'll add around 2.1 million new residents. But you can see that rate of growth over time kind of slowing down because we do factor in those lower births, the lower fertility rate. We also think about this has a little bit higher life expectancy, but that results in more deaths when you have an older population. And then kind of a little bit of muted migration, but we still anticipate a strong economy that will attract people to the state. So all of those things together combine into, around 5.5 million residents in 2060. I will throw out, this is a little bit lower of an estimate. It's not the doubling that we've, that's been the narrative for quite some time. It's a little more reserved, but that's using the information we have now, and we get to revisit these every 4 years when we get new input information. But how that growth is experienced throughout the state is different. As has been mentioned, there are some differences sometimes between our rural communities and our urban communities. We anticipate in these projections that the Wasatch Front will continue to be home to most Utahns. Right now, it's around 75% of Utahns live along the Wasatch Front, so Davis, Weber, Salt Lake, or Utah counties. But then we also have kind of the ring counties, so the ones neighboring the Wasatch Front, adding a lot of residents. And then we also have Southwest Utah, Iron and Washington County, really adding a lot of population. And then you can see some varying degrees of increase throughout kind of Eastern Utah, some of our smaller population areas. And then the map on the right just shows the job growth and how that really makes an impact on that population growth. So that's also going to impact who is living here. If we look back last decade, we saw that over half of our growth in that 500,000 new Utahns came from people who identified outside of non-Hispanic white. So the blue chart on the right just kind of gets into that in a little more detail. The Hispanic or Latino population added a lot of new residents, but then we also had our Asian population grow quite a bit. And then the some other race or two or more races group really grew by quite a bit. And so we're going to continue to diversify. We have a set of projections looking out into the future for race and ethnicity at the state that we're going to update when we get the new census data next year. But we anticipate that this racial and ethnic diversification will continue into the future. And then kind of speaking to that, if economic drivers are bringing people here, that changes our age dynamic and that changes what we look like. We're the youngest state in the nation. However, we are aging. Everyone is aging. Every state has a population of baby boomers who are aging. And in our projections, the millennials are that big group that are the aging group that are kind of driving that older force. So looking out into the future. But you can see on this chart, this just shows the population by age. So bottom is the youngest population going up to the oldest at the top, with the female population in the red and the male population in the gray. And the shaded area is what we look like now, what we look like in 2020. So you can see kind of a narrowing at the base of some lower birth numbers for the past couple of years. The draft data looks like it might have popped up a teeny bit this past year, but we'll see when that gets finalized. But then, a strong working age population and then a smaller, older population. And as we get more, migration, economically driven, bringing people here, and that's one of our big levers of change, that's going to impact what our age structure looks like. So a lot more working age people, again, that cohort of kind of millennials being the old part of the pyramid, and then just lower births overall, kind of narrowing that bottom. So that changes a lot of needs for our health communities to think about into the future. But that is your quick summary of our changing demographics, and I'll turn it back to you.
Great. Well, thank you so much, Mallory. I was telling Mallory, I think that's the first, I obviously don't follow it as closely as she does, but I think when she first shared this slide, it was the first time I'd seen our population pyramid go from that traditional triangular shape that you kind of want to more of the hourglass shape or whatever you call it, which I think is a big change for our state. So I'll just open it up to our panel. I'd love to get any of your initial reactions to the data and what it means for the health of our populations, as well as what our healthcare systems need to be thinking about in terms of staying ahead of these changes. So I don't know if someone wants to go first.
The thing I think about first, Laura, I'll just jump in. I think about the needs that we've talked about kind of coming into Mallory's presentation and how much those needs will be exacerbated as we watch the changing demographics in Utah. The workforce that we have today in healthcare does not match the population we're serving already. And as we become more diverse in terms of race, ethnicity, preferred language, And you can see this as you walk through our schools. Today, our schools are so much more diverse than our hospital patient rooms, if you will. And when we think about those needs, we have to be really intentional as health systems to partner with communities today so that we are developing the workforce we need for the future, or we're going to be just further and further behind in our ability to match those needs in total workforce demands, but also in culturally competent and matched communities, and really creating a relationship of trust. So I think healthcare has to move into community partnerships much more so than we ever have before.
Yeah, I just want to echo that. I mean, that's my initial reaction to Mikkel is like, what are we doing to make sure that our pathways are set up for diverse and even rural communities, right?
Yeah.
So, I think one of the things that comes top of my mind is University of Utah Health recently received a $2 million grant to work with West Side communities to build education pathways in partnership with Salt Lake County, Salt Lake Community College, and to go into these elementary, junior high, high schools and to build with community what is it that are the assets and strengths in the community that we can build on to encourage pathways into healthcare, but then also what are the barriers that we can start looking at, and how can we break those barriers down. And I think the really interesting thing about this partnership is that we're looking at wraparound services. So everything that we talked about earlier, childcare, housing, behavioral mental health access as they're going through school. It's a very stressful time, right? And we're looking at people from all walks of life, not just, not just high school graduates, but also, anybody who wants this as a career pathway. What can we do to build and support them? And so I think one of the biggest things that in these community conversations, I always ask whether it's the health system leaders or the community partners, when you say you want culturally responsive care, what do you mean by that? And how can we address it? And it's really hard to articulate, but I think that this is probably the number one thing that we as large systems can do to become culturally responsive, is to hire people and develop people and train people and build people up from these communities to be the ones ultimately providing care.
And one of the options that we've talked about already on this call before, but community health workers are a key part of being able to make those connections, help people make the connections to the systems that are out there, the services that are out there. It's with the states moving forward in that direction. A bill was passed, and there's an option now to move forward with certification of community health workers. And I think that'll help facilitate the ability to reimburse community health workers for the work they do, which I think will help the role move and evolve from something that often has been grant funded or short-term temporary funded in certain circumstances to something where it becomes more a common part of our healthcare system and reimbursement system, and create some ongoing long-term pathways to be able to fund those positions and those roles. So I think that's an exciting development. I think that's in process, and we'll be moving through the process here.
And what a great pool of incoming culturally diverse workforce, right? So as large systems, how are we thinking about building them up and building pathways once they're hired within our systems, if that's what they want? And so I think it's a really good way to get people in the door and get employed in the healthcare field. And then what can we do as systems to build them up and move on to the next thing, whether that's nursing or pharmacy tech or whatever it might be, right?
Mm-hmm. Yeah, creating those pathways within the system as well. And I was just going to note, related to community health workers, another key theme that we've heard in the assessments that we've been conducting around behavioral health is just the support or the desire for more of those non-clinical care team members, and just the appreciation for how much they do and the value they provide to the system. And so it's great to hear that the state now has a pathway to create that reimbursement for community health workers as well. So, Nate, I want to jump to you with maybe with one more question, and then we'll open it up to audience, see if there's any questions from the audience. If not, I've definitely got some more for our panel. But Nate, I know Utah expanded Medicaid in 2020. Timing wise, that also corresponded with COVID-19 and the public health emergency, which included this federal provision that kept people continuously enrolled in Medicaid, regardless of changes in their eligibility. So simultaneously, we had this expansion of Medicaid. We also had this federal provision that kept people on Medicaid during the public health emergency. I don't think we've heard any official announcement yet of the public emergency ending, but I think officially it might end this week, but we know that there's going to be at least a 60-day wind down. So potentially in 60 days, that might start winding down unless we hear more from the Biden administration. But I was just thinking, when it does come to an end, there's potentially going to be quite a few people that may be disenrolled from Medicaid. So wanted to get a sense of what that population or how many people that's potentially looking like. And also just thinking, our uninsured population, because of Medicaid expansion and because of the public health emergency and COVID and all of these other factors that we've been talking about today with inflation and other issues, our uninsured population in 2023 may look very different than it was in 2019 before all of these other factors hit. I just wanted to get a sense of if you are thinking or if the department's thinking about what that uninsured population in the state of Utah is going to look like moving forward.
Yeah, thank you. As you mentioned, there's a lot of changes that have happened related to Medicaid eligibility over the last couple of years, and that's caused the Medicaid program to really grow at a rate that we've never seen before. In 2019, our average population was just hovering around 300,000 individuals on the Medicaid program, and now we're up over 500,000 individuals that are on the program. Due to the provisions that you're talking about, both our Medicaid expansion and then also the public health emergency maintenance of eligibility requirement that requires us to keep individuals on the program once they enroll. And as we look, as you mentioned, as we look towards or expect that there will be at some date be an end of the public health emergency, we've been working with the Department of Workforce Services, who does the eligibility determinations for Medicaid, what that unwinding process is going to look like. Utah has continued to do its reviews during this process. And so we do have more information than some other states do related to our existing members. But there are a significant number of members who may lose eligibility once this maintenance of eligibility period ends. And so we've been working to communicate with our members to make sure that they get their information updated with us, particularly their address information, because one of the steps that will happen for many individuals is that they will receive a review. And for some of them, it may be the first time that they've had to actually respond to the review and have it impact their eligibility if they fail to do so. So we've encouraged, we put out a lot of messaging to our members, both through our accountable care organizations and directly through our website related to that. We've also encouraged members, some members have heard this discussion about unwinding and have assumed that that means their benefits are over now. And we've had some concerns and had those raised to us. So part of our other messaging that we're sending to members is that they're still currently eligible and they should still use their benefits. This isn't a period where they need to be worried about that. We will notify them when this change occurs, and then they'll need to do some things, but they are currently eligible and they should be able to continue using their benefits. As we look to 2023, what our population might look like after unwinding, we do think that as we do our projections, that over somewhere between 100,000 to 200,000 individuals as they go through this review process may lose Medicaid eligibility. Some of them will be able to transition over to the federal marketplace. Some of them already have private health insurance through their employer or other means and have just maintained that Medicaid eligibility in the background. But the Medicaid population, at least, will be in 2023 as compared to, say, 2018 or 2019, will have a significant higher number of adults and adults without dependent children due to the expansion. And so that will change the cost structure and profile of the Medicaid program. We're meeting with the behavioral health system right now and our accountable care organizations to talk about how we want to structure those health plans going forward. So that we can provide those services in an appropriate and integrated way to try to take advantage of the fact that we're covering both their behavioral health and their physical health And can we coordinate that in a way that maximizes the services to them and ideally would reduce costs too.
Thank you. Well, I wanted to maybe just open it up for questions to the audience. If there's any questions for our panelists, or I'd love to also hear if people have any thoughts maybe about healthcare issues or healthcare needs that haven't been mentioned today that you think are important to highlight as well. As we all know, there's a myriad of healthcare issues and concerns. So I'd love to hear from the audience members if there's some that you think didn't rise to the top that are worth highlighting as well. So but maybe while we're waiting for a couple of questions to come through, Mikkel and Riley, I'll just ask you, love to get your thoughts on what the healthcare systems are doing to address some of these issues. What are we doing now to prepare? I think you've talked about a few of these already. And then what are you thinking about in the future in terms of addressing our state's future healthcare needs?
Go ahead, Riley.
Yeah, I mean, I think the biggest thing on the docket for University of Utah Health is, if you haven't heard, we're building a hospital in West Valley. And so I think that's the biggest opportunity that we have to address some of the healthcare disparities that were identified in the community health needs assessment and have risen to the top through the COVID pandemic. And so we're slated to open this facility in 2027, but it's been an incredible opportunity to partner with community to design not just how the building look and feels, but the programs that are going to be offered. We're working with community to build what does community space in the hospital look like. Before we even hired the architect firm, we had done focus groups and community conversations and made it very clear, handed a packet of information to the architects and said, this is a priority for us to listen to and partner with community. And then we've had the architects meet with community members on an ongoing basis since the beginning of this year. And we've set up, so for me, it's really about it's this unique opportunity that we have to build the scaffolding and the structure in place now to ensure that the hospital going forward is responsive to community. And so we've got a steering committee that meets monthly. We have resident committees that meet twice a month. And we're really diving deep into some of these, trying to find the transformative solutions, right? Trying to find what is it that the community wants and needs, and then how can we as a hospital and large system support them and build them up for the things that they're for their priorities. So for us, that's, I think, the biggest thing that we have that we're doing to address what we've talked about today.
That's awesome. Mikkel.
I love the work that the university is doing in West Valley, and so I'll add that the housing issues that we talked about earlier are now coming to us from all of our communities, and we are working with Zions Bank and Utah League of Cities and Towns to help cities think through solutions around how to create built environment, utilize assets that exist in their communities to address some of these underlying issues, including housing stock. And we have a number of pilot projects that are underway right now that really create opportunities for cities, and we're doing this with our land as well, to think about how do we utilize underutilized or fallow assets even to address some of these gaps that exist, whether it's housing, childcare, and other things, utilizing the resources that communities have and aren't utilizing today. So that's one thing that we're really excited about, and know that it will take a few years to bear fruit. In a more near-term way, we're also really trying to address behavioral health access. We have a goal as a system to double the amount of behavioral health we're providing as a health system. And looking at, that encompasses everything from peer-to-peer type of support, telehealth capability, video visits, and direct access into traditional in-person care, with an eye towards how are we expanding access in linguistically and culturally competent ways in rural communities, not just those urban settings where we often see growth. And so looking at it across that spectrum, and really believe that's going to be critical. And I'd say more than ever, we're all a part of finding those solutions. The Live On campaign now has a component dedicated towards how do we apply some of our behavioral health programming through employer responsive resources. And we've worked really hard to create telehealth capability in all of our schools so that we can create extensions of the behavioral health infrastructure that can reach kids and teachers and faculty right in the school setting. So thinking about the ways that we expand access that are non-traditional is a key component of that work.
Laura, Mikkel just reminded me, we also, I think in the shorter term as well, before the hospital in West Valley is built, we're working with Huntsman Mental Health Institute's building the Campus of Hope in South Salt Lake. And it's going to be a receiving center for behavioral health needs in the community, as we talked about, is one of the biggest needs. And so it's another tool in our toolbox, so to speak. And we're also in that facility as well. We're building it with community partnerships, and we're looking at things like medical, legal partnerships, addressing legal needs of community members, having folks like Latino Behavioral Health Services on site. And so it's going to be, again, just another tool that we can use to reduce that gap in behavioral health services in the state.
Yeah, that's awesome. I love how both of the systems are really thinking about broader than just healthcare, medical care, and really getting out into the social determinants of health and figuring out how to address those. Because again, increasingly know and understand just how much of an impact that those have on healthcare outcomes. We did have a couple questions come in. The first one was about nursing staffing shortages specifically. Just wondered about the impacts that you all are seeing with the nursing shortages and what's being done, if anything, to address those shortages, particularly any partnerships with universities or other training programs to increase the Utah's nursing population workforce. So,
I mean, go ahead, Nate.
Oh, go ahead, Riley.
No, Mikkel and I have been talking a lot. You go ahead, and then I've got.
So one of the areas at Health and Human Services, we directly employ nurses related at our state hospital and our developmental center, and along with many other professions over the last year, have had severe shortages in those areas. In the short term, one of the things that we've been looking at is related to salary issues and signing bonuses and those things, and I'm sure the health systems are also doing similar things as we're doing that. We're also looking to work on things related to the safety of the population of our healthcare professionals and being able to support them. I believe it was mentioned earlier, sort of the mental health and the behavioral health issues that our professionals face as they deal with very difficult situations. And so those are some things that we're trying to do to support our nurses and other healthcare professionals that are working in some of our facilities.
And I'll just, University of Utah recently increased its enrollment in the College of Nursing by 25%. And I thought what was interesting when we did that, there was a statement about 1 in 5 Utah nurses are approaching retirement age. And then you have all of the things that we've talked about today that are causing people to switch professions or maybe go to something that's a little less intense, so to speak. And so I think there's a lot that we need to do to address the health and well-being of our population. And so I think, so now we have 3 cohorts. I think it was 36 students that were able to graduate additional per year now. And so I think it's just keeping our eye on what does that training of the future workforce look like. And it's not going to be easy, but it's something that we all are grappling with.
Mm-hmm.
I'll add a couple of additional things. One of the things that exacerbated the nursing shortage during COVID was the use of traveling nurses to try to adjust for fluctuations that were occurring around the country and address some of the workforce gaps just created by stress and people moving home to take care of kids or do school, those kinds of components. And what we've found is that agency staffing model has been attractive to nurses who don't need benefits designed in a way that in a kind of a traditional benefits design way, and could choose working arrangements for a period of time and then take a gap. But it unnecessarily raised the cost of providing nursing care for all of our health systems across the country, which created a competitiveness for recruiting. And those same nurses who might have worked for one of our hospitals here might sign on with an agency and then come back to work in our same facilities. And that was really created a cycle of frustration for people working in the field as well, who found those then pay disparities in their in what they were experiencing. And so one of the things that we've been doing, kind of listening to our nurses, is thinking about how do we create that same opportunity for work environments within our systems instead of creating this additional marketplace for agency nursing work, and really create I think it gets in part to addressing pay issues, but also work environment issues. What do people want in their work climate and environment? And how do we create that right within our system? And so that's been a big focus of our work and has helped us to nearly eliminate the use of agency nursing to staff our facilities and create greater satisfaction for nurses working at Intermountain as their home base. And I think that's a really important part of evolving the way the nursing workforce, the way we think about nursing and the way we support nursing in mental health, in putting additional non-nursing support around nurses so that they're able to work at their top capability and performance, but also health and well-being. And so that's a really critical component. And then in addition to expanding the number of nursing training program spots, I think ensuring we have those clinical training rotation options, and that we're creating the pipelines into nursing as well. Having pipelines through MA, community health worker, CNA types of programs that attract workers into healthcare earlier will be really critical. And that's been a key emphasis for us as well.
Well, we've got maybe time for one last question, and it's kind of a big one. So, but it came in from the audience, and I would love to hear what people think. But it is, are we more or less prepared for another pandemic? I thought that was a great question. I don't know if it's easily answerable in 2 minutes, but other parts of the question include, what other strategies do we need to be thinking about to improve our readiness? So Nate, maybe I'll jump to you, since you obviously worked very closely with a lot of our COVID-19 response, but would love to get your thoughts on that. I'll just say, I don't know if you can ever be ready for a pandemic, but would love to hear from you.
True. I would definitely say right now, I think we're more prepared. Our systems have built up capacities. We have warehouses, we have materials, we have staff. There's extra federal funding still flowing through our systems. I think our capability right now is higher than it was going into COVID-19. My concern, and for those in the public health realm, is what happens traditionally once these crises pass, is that as time goes on, the remembrance of how bad it was and what we had to do to be ready for it fades, and our preparedness wanes. And so I think one of our challenges is to figure out how we maintain some of those core capabilities to be ready for the next response. Well, there were some things that broke during the system that we hadn't expected or hadn't fully anticipated how badly that they would break, as far as like supply chains and those sorts of things. And what do we do to sustain those? And it costs time and money to do that. So I think we're more ready now. I think it's a challenge to keep that readiness.
Great. Yeah, absolutely. Mikkel Riley, any last words that you'd want to add?
I think we have our ability to build partnerships and our demonstrated ability to work together at the state with Department of Health and Human Services across health systems. I think it really showed that we can work together and do hard things together. And for University of Utah Health, I think we saw where our deficits were, and we're actively working to improve them. And one example of that was 25% of our patient population, we didn't know, what race or ethnicity they were. And so we weren't able to contribute to some of the health disparities work. And so we're actively working on increasing the capture rate for that data so that we can better address health outcomes and health disparities. And that comes with training our frontline staff how to ask the question. We've increased the options so patients can see themselves in the data offered from less than 10 options to over 80. And so we're really trying to be responsive to the community, but then make sure that they want to share that data with us and understand why we're asking.
Yeah, I'll just close, Laura, by saying I'm optimistic that the lessons learned through COVID around health disparities, partnership, and collaboration have longer term impacts on addressing the other health issues that are systemic in our system today. And it leaves me optimistic. So I'll close with that. Thanks, Laura.
That's great. I love that note of optimism. I was hoping to end on something optimistic, so I really appreciate that. Well, I just wanted to say thank you. This concludes our Newsmaker breakfast today, and I just wanted to give a huge thank you to our panel for joining us today and sharing their thoughts and sharing their expertise as we move out of the pandemic, but really start focusing, I think, on those critical issues that are facing our state today in terms of health and social determinants of health, and having that much broader view of addressing the needs of our state. So thank you to the audience and your participation today as well. I'll just note that our next Newsmaker is November 9th at 8:30 a.m. And if you have any additional questions, comments, or feedback, please write us at gardnerinstitute@eccles.utah.edu and follow our social media channels on Facebook, Twitter, LinkedIn, and Instagram for our latest updates. Stay safe, everyone, and thank you again.